Hello everybody. So today our class is on rheumatic fever. It's a very important topic, so please listen carefully. The class might be a bit lengthy, but it's a very important topic for both. You mainly get long questions on rheumatic fever. You can be asked in Viva. You can be getting short notes on the management or on the prevention. Okay. So let us first see what is rheumatic fever. First thing is that don't get confused between rheumatic fever and rheumatoid arthritis. The etiology of both of these, is completely different. Rheumatoid arthritis is an autoimmune disease which is mainly affecting the joints. Rheumatic fever, yes, it is also caused by the immunological damage occurring to the different organs, but the main reason why this rheumatic fever is occurring, that is completely different from that of the rheumatoid arthritis. So let us first see what is rheumatic fever. Rheumatic fever, in this rheumatic fever, the patient develops a systemic inflammation. It's a systemic inflammatory disease, and this mainly occurs as a delayed sequel to pharyngeal infection. Means initially the patient develops a pharyngeal infection. Okay, so initially the patient develops a pharyngeal infection by which bacteria? That is your group A beta hemolytic streptococci. Remember, group A beta hemolytic streptococci. So, and around, this is again a very, very big confusion. Remember, rheumatic fever is not this. See, this pharyngeal infection, this the which the patient is developing. This is an infectious thing, and this is being caused by this bacteria. But rheumatic fever, when the patient develops rheumatic fever around 1 to 5 weeks after the patient develops this infection, pharyngeal infection, when the patient develops rheumatic fever is not due to any infectious cause. It is a immunological damage which is occurring to the heart valves and joints and subcutaneous tissues. Okay, so now you might think, how is this happening? Like first there was the infection, and then there is a immunological damage, and this rheumatic fever is basically, it is occurring because of this immunological damage to the different organs in our body. Like it can be heart, cardiac, muscles, the endocardium, pericardium. Okay, and the skin, it causes subcutaneous nodules. Okay, subcutaneous tissue. So how is this occurring? See, what is the etiology behind this is that the pathogenesis of rheumatic fever. One more thing I want to say you, that rheumatic fever, it mainly occurs in the childhood. Remember, 5 to 15 years of age. This is the most vulnerable period, where children often get affected with this rheumatic fever. Usually children who are younger than 5 years or even less than 3 years, they have got very less chances of developing rheumatic fever. Okay, so this is childhood. This is the most common time when the patients, when people develop rheumatic fever. And one more thing which often might be coming in your brain, in your head, that will all the patient who will develop pharyngeal infection with beta hemolytic streptococci will get rheumatic fever? No. Okay, even less than only 2 to 3% of the patients who get this infection with this hemolytic streptococci, pharyngeal infection, they develop rheumatic fever. Okay, one more query which you can think about, that is, what if I get a skin infection with beta hemolytic streptococci? I don't develop a pharyngeal infection, but I develop a skin infection with streptococcus. Will that also carry a risk of rheumatic fever? Again, your answer will be no. Okay, only mainly when the beta hemolytic streptococci, there occurs pharyngeal infection due to beta hemolytic streptococci, you can develop rheumatic fever, and that also the chances only 2 to 3%. Okay, next let us look at the pathogenesis. After all, why is this happening? First, initially there is an infection. After 1 to 5 weeks, why will there be a immunological damage to the different organs? Okay, so first what happens, you all must be knowing, whenever a foreign antigen enters our body, whenever our body faces a foreign antigen, what does the body do? The body will start producing antibodies against it. Okay, similarly, when there is a pharyngeal infection by this beta hemolytic streptococci, our body will start producing antibodies against this streptococcus. Okay, the streptococcus, it expresses different types of antigens. Usually the antigens expressed by streptococcus, they are called as super antigens. Super antigens. And the M protein, okay, the M protein of the streptococcus. So the our body starts producing antibodies against the streptococcal antigens. But by the time our body produces these antibodies against these streptococcus antigens, this infection has already resolved. Either the patient, maybe by the time the antibodies has developed in his body, by that time this infection has already resolved. Now what will happen is that those antibodies which our body had produced against the streptococcus, these will start attacking our self antigens. Okay, our body's organs. Okay, so it will start attacking its self antigens. The antigens which are inside our body, like I'll just tell you why is it so. Now you might think, why is it so? The antibodies were being produced against the streptococcus, but why is it attacking our own body organs? This is because, this is important, this is due to a phenomenon which is called as, this you should remember, molecular mimicry. Molecular mimicry. What do you understand by molecular mimicry? Molecular mimicry means, I'll just tell you with example to this. The antigens of this streptococcus, they bear a close resemblance with our self antigens. Okay, this antigens which streptococcus has expressed, against which our body produced antigens, against which our body produced antibodies. So those antigens, they bear a close resemblance. There is some sort of similarity between the streptococcal antigens and our self antigens. Therefore, the antibodies which are produced against the streptococci, these will attack our self antigens. It will interact with our self antigens, and it will start causing damage to our, the organs of our body. So this is what is called as molecular mimicry. Okay, so as a result of the streptococcus infection, there will be the production of antibodies inside the body. The T cells, B cells, they will become autoreactive, and these autoreactive T cells, B cells will now start attacking our own body organs. Like the heart will be involved, skin will be involved, the subcutaneous tissues will be involved, pulmonary lesions, lungs are also involved, which is called as rheumatic pneumonitis. Okay, so all these organs, these antibodies and these autoreactive T cells, B cells will start attacking them. And we get all the signs and symptoms of rheumatic fever. Correct? So remember, rheumatic fever, it is caused due to a prior infection, but what is happening when these organs are getting damaged? That is not because of the bacteria. The bacteria is not causing the damage of the cardiac valves and endocardium and pericardium and skin and lungs, but rather the destruction or the damage which is occurring to the organs in our body. This is a immunological damage. Okay, this is being caused by the antibodies which our body, or the autoreactive T cells, B cells, which our body had produced against the streptococcus bacteria, against the streptococcal antigens. This is very important. Okay, next let us see what are the, let us see, okay, let us then next come to the clinical manifestations. Okay, so how will the patient present to you? Remember, when the patient presents to us, when the patient comes to us, so most of them will come with this polyarthritis. And here polyarthritis means, arthritis which is involving more than 2 joints. Okay, so at least it is involving 2 or more than 2 joints. Okay, so okay, so next what you should know is that, okay, and in these patients, they have got a typical type of polyarthritis. That is, they have got a migratory polyarthritis, migratory or the fleeting nature. We say this is the type of arthritis, migratory polyarthritis or the fleeting polyarthritis. What do you understand by migratory or fleeting? I'll just show you this thing, a pic. Migratory, what is the meaning of migratory? But it is migrating, isn't it? Just a minute. Okay, look. So here in this rheumatic fever, can you see this, the different joints which have been, highlighted with this red color? Okay, so you can see, so first the patient will tell you, okay, initially there was pain and there was redness in this joint, in the shoulder joint. And then then what happened after a few days now, this the pain and inflammation in this shoulder joint got resolved, and then then again the elbow joint started getting affected. Then there was pain and redness in the elbow joint. Then after some time this got resolved, no more, there was no pain and swelling in this joint, and then the wrist joint started getting involved. This is what is called as migratory. First one joint will get involved, and then that thing will resolve. Okay, the pain and inflammation will go away, and then the next joint will be involved. Then here also it will stay for some days, then here it will get resolved, then it will move to the next place, next joint. Okay, so this is what is called as migratory or fleeting polyarthritis. And here the most commonly involved joints are the large joints. You can see the shoulder joint, elbow joint, wrist joint, knee joint. Okay, so all the big joints, they are mainly involved here. Right, so here the affected joints, when you examine the affected joints, you can see pain and there is redness. There might be effusion or there might not be effusion, but pain and inflammation is almost always present. And after some time, after a period of time, as I told you, first this joint will be involved, then this joint will be involved, and like this, there's a migratory. When the patient will tell you, you can understand. The patient will complain to you like this of migratory polyarthritis, and then the next thing which you can think that what will happen, like after a certain period of time, this entire thing will resolve. Okay, the patient, these involved joints will heal. Then you can ask that, will there be any deformity? Like often you must have seen in patients of rheumatoid arthritis. Okay, so those patients, initially there is pain, swelling, inflammation in the joints, and later, there is some sort of deformity. Those patients develop different types of deformity in the joints. But here the thing is that these patients don't develop any residual deformity. There is no residual deformity even after, after the things get resolved. There is no residual deformity in the joints. Okay. So this is one thing which you should know about these joints. In fact, this is the most common presentation which the patient will come to you with. And in this case, when the patient comes to you with this presentation, what is the thing which you are going to ask the patient? You will ask the patient, do you remember that around 3-4 weeks ago, or 1 month ago, did you have any sore throat? Okay, so you will take a history of sore throat from the patient if you are suspecting it is a rheumatic fever. Okay, so but unfortunately most of the people don't even recall. Okay, like around 2/3 of the patients, they will tell you, yes, I had a sore throat. Okay, I took some medicines for it, or maybe I didn't take anything for it, I just it went away on its own. So a few people remember, but most of them don't remember. Okay, so you have to take a history of sore throat from the patient. Then what else? In these situations, remember, if the patient has developed polyarthritis, if you get a the history of sore throat, then the most important organ which this rheumatic fever affects, that is your heart. So the patient can also present to you with manifestations of carditis. Okay, but the thing is that carditis developed, it's not that all patients of rheumatic fever will develop carditis. Only 40 to 50% of the patients of rheumatic fever develop carditis. And what are the features of carditis? Like, in the heart, all the 3 layers can be involved. That is the myocardium, this can be involved. Okay, okay, I should have started with, okay, let us do like this. The pericardium can be involved. Okay, the myocardium can be involved, or the endocardium can be involved. So depending upon what is involved, and whether, sometimes all the 3 layers are involved, you will get the different manifestations. And it's not necessary ki always what happens is that usually those who develop carditis, they develop quite early, within 3 weeks of the onset. Okay, so the features of carditis, they develop within 3 weeks of the onset of carditis. But sometimes what happens, like in young children, it's also asymptomatic. Although the patient has developed carditis, maybe you won't get any symptoms in those patients. So in those cases, like if you are suspecting ki yes, this patient has got a rheumatic fever, you should advise an echocardiography, because sometimes on echocardiography, you can find the changes which can occur. And the changes, I'll just tell you that what happens in the pericardium and what happens in the myocardium. Okay. And what are the changes which occurs in the endocardium. So what do you think will occur in the pericardium? Pericardium, actually, there is going to be in the pericardium, there will be pericardial effusion. Okay, so in the pericardium, there will be pericardial effusion. There will be a thick serous exudate, and it gives you, when you look at it macroscopically, it gives you a bread and butter appearance. Okay, so bread and butter appearance. This is sometimes it's asked in the MCQs and all. So bread and butter appearance of pericardium that is seen due to the exudate, the thick serous exudate, the pericardial effusion, which occurs in rheumatic fever. Okay. Now, what about the myocardium? About the myocardium, you should know how is the myocardium affected. Again, I'll show you a pic here. See here, look at this myocardium. This is, a microscopically, we have viewed the myocardium. And can you see here the Aschoff bodies? Aschoff bodies, look at here. I'll just put it in slideshow mode. Yes. Look at these, the Aschoff bodies. Aschoff bodies, okay? So can you see this purple color, this Aschoff giant cells? Okay, can you see this fibrinoid necrosis in between these cells, the fibrinoid necrosis in between? This is a microscopic view of the Aschoff bodies. Actually, in the myocardium, that shows, when you look into the myocardium shows this Aschoff bodies. Okay, this Aschoff bodies, they are the small granulomas, and there is a central zone of fibrinoid necrosis. You can see the central zone of fibrinoid necrosis. It is surrounded by lymphocytes and plasma cells, and you have got these Aschoff giant cells also. Okay, so in fact, these Aschoff bodies, they persist for many years in the chronic rheumatic inflammation. Okay, and eventually, when these Aschoff bodies will heal, they will leave behind a triangular scar, okay, spindle-shaped or a triangular scar. So this is the change which you can see in the myocardium. In the myocardium, you can find these Aschoff bodies in acute rheumatic fever. In myocardium, you can find these Aschoff bodies. Okay. And how will the patient present to you? If the patient has got myocarditis, if the myocardium is involved, you will find here the tachycardia. Okay. So the heart rate is quite increased. Okay. There is tachycardia disproportionate to fever, dropped beats, S3 and arrhythmia. Sometimes there can be features of heart failure, and important one thing, that is your fetal heart sound. What do you understand by fetal heart sound? See, this is what you can see microscopically. Okay, so in microscopically, you can see the Aschoff bodies, but this, what I'm saying you, is what the manifestations of carditis. Okay, so in manifestations of carditis, you can hear the S3 beats. Okay, so you can get some features of heart failure, tachycardia, dropped beats. Okay, and the thing is fetal heart sound. What do you understand by fetal heart sound? See, how does a normal adult heart sound sounds? Labda. Isn't it? The S1 and the S2, they have different pitch. Okay, the S1 and S2, they have got different pitch, labda. But in fetal heart sound, the two, the first heart sound and the second heart sound, they are almost of the same pitch, and they're evenly spaced. So that is why, since they are almost of the same pitch, that is why we call them tic-tac quality of the fetal heart sound. So you are going to hear this tic-tac quality of the fetal heart sounds. Okay, so these are the features of your myocarditis, manifestations of myocarditis. Okay, next let us come at the endocarditis. Endocarditis means, what do you think, what is going to be involved in endocarditis? Valves will be involved. Okay, the valves will be involved. Just a minute. Yes, look at this one. So can you see? Yes. So look at these. This is your valve. And what are these? What are these? These are the vegetations. These are the numerous small rheumatic vegetations on the line of closure of the mitral valve. You remember rheumatic fever, the most common valve which is involved is the mitral valve. Very important. Okay, followed by the aortic valve, and the rest two valves are rarely involved. Tricuspid valve is very rarely involved, and pulmonary valve is almost never involved. Okay, so the most common valve which is involved in, it's often asked, okay, the most common valve involved in rheumatic fever is the mitral valve, and you can find this numerous small vegetations along the line of closure of this mitral valve. Okay, so this is one thing which you can see. And what is this called as? This is called as there is an inflammation of the valves, numerous small vegetations along the line of the closure of the mitral valve. And later, when there will be healing, it will lead to the fibrous thickening. These valves, they will become thickened. Okay, and there will be adhesions of these valve commissures and these leaflets. So there will be adhesions between these two leaflets of the mitral valve. There occur adhesions in the leaflets, and there will occur in the chordae tendineae. Okay, so there will occur fibrous thickening. First initially these verrucous vegetation, these vegetations, numerous small vegetations will appear, and later on, when they will heal, this will lead to the thickening of these mitral valves. There will be adhesion between the leaflets and the chordae tendineae. And what will happen if there is adhesions between these leaflets and this chordae tendineae, and there is thickening of these valves? What will happen if there will be thickening of these valves? There is going to be mitral stenosis. There can occur mitral regurgitation. Okay, so all these problems will start occurring. Okay, so this is how the endocardium is involved. As I told you, mitral valve is the most common valve to be involved. And what manifestations will the patient present with? If the valves are involved, if there is mitral stenosis, or if there is mitral regurgitation. So let us first talk about mitral regurgitation, which is in fact the most common. Mitral regurgitation. Remember, since these valves, leaflets, they become thickened. Okay, so therefore they are not able to close properly. So we mostly get this mitral regurgitation. And in mitral regurgitation, what kind of murmur can you, although murmur we'll be covering after this. So I'll be telling you in MS what kind of murmur you can hear, in MR what kind of murmur you can hear. But for the meantime, since we are discussing about this MR, mitral regurgitation, what kind of murmur can you hear in mitral regurgitation? We hear a apical systolic murmur. Okay, so what happens is that you auscultate the chest. If you can hear any murmur, systolic murmur, apical systolic murmur of mitral regurgitation, you go to the wards, you see patients, then you can distinguish these murmurs very well. Okay, or there is one more thing. Sometimes, there develops nodules, small nodules on these valve leaflets. Okay, so because of this nodules on the mitral valve leaflets, there occurs another type of murmur, which is called as Carry-Coombs murmur. Okay, so Carry-Coombs murmur. This is your apical mid-diastolic murmur. Okay, apical mid-diastolic. This is systolic, that was apical mid-diastolic murmur. Or sometimes, as I told you, mitral valve is the most common valve to be involved. But if the aortic valve is involved, it will lead to aortic regurgitation. And here you can get the early diastolic murmur. In atrial regurgitation, we get the diastolic murmur. So early diastolic murmur of atrial regurgitation. Okay. So in an individual, when you're suspecting a rheumatic heart disease, if you find, the appearance of this new organic murmur, or there is any change in the previous murmur, okay, appearance of a new significant murmurs, that usually goes in favor of endocarditis. Okay, so I told you about pericarditis. Pericarditis, there is pericardial effusion, and you get, macroscopically, there's a bread and butter appearance. And the patient, what are the manifestations of pericarditis? The patient will come to you with chest pain, pericardial friction rub, and myocardium. I told you, pathologically, when you look, microscopically, you can see the Ashkoff bodies, Ashkoff giant cells, and the fibrinoid necrosis in the center. Okay, and features, you will find the features like tachycardia, features of heart failure, S3 dropped beats, fetal tic-tac sound, endocarditis. Mainly the valves are involved, and you can hear the different types of murmurs depending upon which valve is involved. If the mitral valve is involved, you'll hear the systolic murmur. If the aortic valve is involved, you'll hear the diastolic murmur. Okay, so this is all about your carditis. Okay, so I told you the manifestations of carditis. Okay, next. Let us come. This is very important. Carditis is, in fact, you all should know about the manifestations of carditis. Okay, next, which all organs can be involved here? First, I told you about the arthritis, then I told you about the carditis. Next, let us talk about the subcutaneous nodules. Okay, the patient develops small, painless nodules. Okay, and this is usually associated with severe carditis. And, the nodules, they develop several weeks after the onset of carditis. So here you can see small, again, we can see it here. You can look at here. Look at this nodule. This is a quite big nodule. Look at this one. This one. Okay. Look at this one. Look at this one. These are very small and pea-sized and painless nodules. And sometimes, like patients, even they forget, they don't notice it, or even the doctors also they fail to notice it unless the patient comes and tells you. Or sometimes there they can develop inflammation in these areas. Then it comes to notice. It's small pea-sized, painless nodules, and the most common sites are these extensor tendons of hands and feet. Okay, so hands and feet, extensor tendons of hands and feet. This is the most common site. Elbows, patella, and for how many days will they persist? They persist for 1 to 2 weeks. Okay. Next, come to erythema marginatum. This is a erythema marginatum. Look at this picture. Yes, this is a skin rash. Okay, this is the erythematous pink rashes. You can see here there's a clear center. Okay, there is a clear center. Look at here. There is a clear center, and it has got some serpiginous margins, round or serpiginous margins. And these rashes are also transient and migrating. Like, the patient will say, I just saw a rash here yesterday, and today, I don't know, it disappeared, and I saw another rash here. So these are transient rashes. And again, this doesn't develop in all the patients. It only develops in 10%. Okay, 10% of the patient develop erythema marginatum. They are non-pruritic. They don't itch. Okay, so they are not painful. They don't itch, and they are transient, and they are migrating. And we most commonly see them on the trunk. Okay, so we never see them on the face. Never on the face. Mainly we see them on the trunk. Okay. Okay. Next feature. What else can develop? Next is your chorea. What is chorea? Look here. What is chorea? That is what is called as Sydenham scoria. What is Sydenham scoria? Sydenham scoria. Sydenham scoria, these are some sort of abnormal, can you see these are quite abnormal movements? Look at this hand. Okay, so look at this hand and leg movements. They are the quite involuntary, abnormal muscle movements. Okay, so these are called as Sydenham scoria. These are the choreic movements, muscle weakness, and these are very abnormal, involuntary movements. So mild cases, they just appear, they are sometimes difficult to diagnose, but there are three things. Just again, convert it into, okay. Okay, so there are three signs which can be helpful to make the diagnosis whether the patient has developed chorea or not. That is three things, three features of chorea. I'll tell you. One is these are the signs which you have to demonstrate in the patient. I'll just tell you how will you demonstrate. One is your milkmaid's grip. Another is your bag of worms appearance. Bag of worms appearance. Another is the jack in the box sign. Remember these things. Okay, sometimes it is asked to you, how will you demonstrate chorea in the patient? Jack in the box sign. So what happens is that milkmaid's grip, how will you demonstrate this milkmaid's grip? So we ask the patient, the patient is asked, like we just, we ask the patient to squeeze our fingers. Like we just tell the patient that, you squeeze our fingers. Okay, so normally when you squeeze someone's finger, you just squeeze it like, how will I say, like suppose, this is a patient's finger. Okay, so you are telling the patient to squeeze the finger. So obviously the patient should maintain a constant grip over the finger, isn't it? It should not be like the patient is squeezing and suddenly again relaxing, again squeezing and relaxing. You never do like that, isn't it? Suppose you, like in normal individuals, I tell you that squeeze this thing. So you'll hold it tightly, you'll squeeze that tightly. But these patients, what happens is that they are unable to maintain the muscular contraction. Have you ever seen, the milkman milking the cows? How do they milk the cows? They first squeeze it and again release it, squeeze it and again release it. That is how the the milkman milks the cows, isn't it? So some similar type of thing you can see here. When you tell the patient to squeeze your fingers, instead of holding it tight, first the patient will hold it tight and again the patient will relax it, and again hold it tight and again relax it. So this is what is called as the milkmaid's grip, squeezing and relaxing motion, because these patients are unable to maintain this contraction, muscular contraction. Okay. Okay. Then next is bag of worms appearance. Bag of worms appearance, when you tell the patient, when you examine the lingual, the tongue muscles, you will see some sort of asynchronous contraction, just like a bag of worms. Okay. Just like, wriggling type of contraction, wriggling, something. So when you examine the lingual muscles, the tongue muscles, you'll find some sort of, wriggling type of movement, because of the asynchronous contraction of the tongue muscles, bag of worms, when you examine the lingual muscle. Okay. Then jack in the box. Jack in the box is when you tell the patient you tell the patient, come on, protrude out your tongue. Take your tongue out. Okay. You'll find that, the patient will take his tongue out and immediately he'll pull it back. It retracts involuntarily. He doesn't do it voluntarily. It retracts back involuntarily. So that is what is called as jack in the box sign. So these are some of the well established things which are these are some of the signs, some of the signs which you can see in the patient. And apart from this normal, like you can get just very well established things. You can get, like, you can just see these patients, look at these patients. Okay, you can just find that these patients come to you with the abnormal involuntary movements. There's a fast jerky involuntary movements of the extremities. Okay. And in facial chorea, usually there is blinking, there is slurring of speech. So in these well-established cases, you don't need to do all these tests. But in case if you're doubting these not very well-established cases, you can go for these signs. And then you can, if these come out to be positive, this means that the patient has started developing Sydenham's chorea. Okay. So this is very important. And what is the treatment if the patient starts getting the Sydenham's chorea? What do we do? We complete mental and physical rest. And sometimes if it is too much, like too much of abnormal involuntary movements, then we often give the patient sodium valproate, or we can give the patient diazepam, haloperidol. And obviously you have to give the prophylaxis, rheumatic fever prophylaxis, that we'll discuss later on. So this is about your Sydenham's chorea. Okay. And any other clinical manifestations? Yes, sometimes, the patient also gets fever, ESR is raised, okay, arthralgia, abdominal pain, epistaxis. Okay. And okay, then let us come to laboratory investigations. Okay. Okay. So let's come to the laboratory investigations. So what are the things which you are going to investigate in the person when you're suspecting that the person might have a rheumatic fever? What are the things you are going to diagnose? What are the laboratory investigations which you are going to do? Remember, the most common diagnostic infection, the most common laboratory investigation which we do in the patient, that is mainly the serological test, that is the streptococcal antibody tests. Okay, antibody test is the most common and the most sensitive and confirmatory test which we do in the patients with whom we are suspecting a rheumatic fever. Okay, and only in a minority of the cases, only in very less minority of the cases, we might, do the throat culture. Why we shall do for the throat culture? So that to isolate the group A beta hemolytic streptococci from the throat. Okay, but however, this throat culture is not preferred. The most common preferred test is your antibody test, streptococcal antibody tests, or your serological tests. So which are the antibody tests which we are going to do in these patients? The common serological tests are your Aso test, okay, anti-streptolysin O test, your anti-DNS B test, anti-DNS B test, anti-hyaluronidase test, or just write AH, okay, the anti-hyaluronidase test, and you have got your anti-streptozyme test, anti-streptozyme test. Okay, so these are the tests which is done, and remember, out of which this anti-streptozyme test, this is a very sensitive indicator of recent streptococcal infection. Okay, so it's very sensitive for recent streptococcal infection. And when you do all these four tests together, totally all these four tests together, that gives you, if all these four tests come out to be positive, that means you are 95%, it gives you a 95% accuracy. Okay, so this is very important. And the most out of these four, even if you don't do all the four, the most common test which is done, this is the ASO test. It is anti-streptolysin O test. It is told that, when the single titers of anti-streptolysin O, if it is more than 250 TOD units in adults, 250 TOD units, is more than 250 TOD units in adults, and if it is more than 333 Todd units in children older than 5 years, then it is taken to be positive. And even more sensitive is a rising titer. Okay, so a rising titer, if you take titers, and if you find that there is a rise in the Aso titer, rising Aso titer, that is even more sensitive. Okay, so these are the different antibody tests which you are going to do. Okay, next, what else are we going to do? There are some other tests, which confirm the presence of an inflammatory process. Just now I told you that rheumatic fever, it's a systemic inflammatory disease. Okay, so what are the inflammatory markers which you can see in the patient? ESR. ESR is often raised. CRP, C-reactive protein, this is raised. Okay, and what other tests can you do which can confirm that inflammatory process is going on inside the body? Sometimes there is increase, the leukocyte count. There is the polymorphonuclear leukocytosis. Okay, polymorphonuclear leukocytosis. Okay, so there is a rise in the leukocyte counts, and there sometimes also you can find a rise in the the serum mucoproteins like alpha 2 gamma globulin. Okay, so there is a rise in the serum mucoprotein levels, alpha 2 gamma globulin levels. So these are the different tests which you can do to confirm that a systemic inflammation is going on inside the body. So what changes are you going to find in the ECG? Okay, the most the most common abnormality, in fact the most consistent abnormality which we find, that is there is a prolongation of the PR interval. Okay, so there is a prolongation of the PR interval. So this PR interval, okay, so this is prolonged. And in the chest radiography, if the patient has developed heart failure, then you will find the features of heart failure in the patient. Okay. In the echocardiography, if the patient has developed, any valve dysfunction, in the echocardiography, if there is a valves are involved, you'll find the valvular dysfunction. You can see the vegetations, you'll find the valvular dysfunction. If the myocardium is involved, you'll find the myocardial dysfunction, right? So these are the different tests which you are going to do in the patient, right? First, throat culture, antibody test for determining confirming the presence of inflammatory reaction inside the body. Then go for the different ECG, echo, chest radiography. So these are the different test investigations which you are going to perform in the patient. Okay. Next, diagnosis of rheumatic fever, acute rheumatic fever. Very, very important. Zones criteria, revised zones criteria. This is a very, very important thing which all of you should know. Revised zones criteria. So what is this revised zones criteria? Under this Jones criteria, there are two things. One is your major manifestation. Another is your minor manifestation. You have to remember it very thoroughly. It's very, very important. Okay, major criteria, all the things which I had told you in the beginning. What was that? Polyarthritis. Yes, the joints are involved. That comes under the major criteria. Then carditis, heart involvement. Okay, so that comes under the major criteria. Chorea, the involuntary movements. Erythema marginatum, the skin rashes, transient skin rashes with a clear center, the erythema marginatum. Remember all the slides which I showed you, everything will come under the major one, the polyarthritis, carditis, chorea, erythema marginatum. And what else picture I showed you all? That is subcutaneous nodules. Okay, so these I showed you in the pictures in the slides. Okay, so these all come under the major criteria. Minor criteria, you'll get a raised ESR. Okay, so you will get a positive CRP. Okay, and what else? The prolonged PR interval. Okay, so there will be fever, arthralgia. So these come under the minor criteria. Okay, so how will you determine that the patient has got, what is the thing that you need to, how many major and how many minor criteria should a patient, should you satisfy to confirm that it is an acute rheumatic fever? Remember, there should be at least two major, that will be different pen, yes. There should be at least two major criteria. Okay, at least if there is two major criteria, then it's fine. Or if there is at least, one major, if you are out of all these, 1, 2, 3, 4, 5, and all the 5 criteria, only one major you're getting, plus at least you have to find out two minor criteria. There should be two minor manifestations. If it is two major, it's fine. You don't need of going into the minor. But if you at least get only one major criteria plus two minor manifestations, that indicate a high probability. Plus, not the only thing. This is not the only thing. That two major criteria or one major criteria plus two minor criteria with one supporting evidence. Along with these, there has to be one supporting evidence that the patient, this is common for both, the two major criteria plus one supporting evidence, one major, two minor plus one supporting evidence. What kind of supporting evidence do we need? Okay, plus one supporting evidence that the patient had a history of the patient had a preceding streptococcal infection. Now, how will you confirm that the patient had a preceding streptococcal infection or not? So what are the things by which you can confirm that the patient had a preceding streptococcal infection or not? Tell me. That is the antibody tests. Okay, the increased streptococcal antibodies, the serological test, the antibodies. As I told you, the anti-streptolysin O and the anti-DNase B and anti-streptozyme, those antibody tests, if they come out to be positive, or if there is the throat culture, okay, so if there is a positive throat culture, or if the patient tells you, that the patient had a recent scarlet fever. Okay, so these are the supporting evidence. So at least one supporting evidence has to be present. Along with that, two major or one major plus two minor criteria. Very, very important. Remember, revised Jones criteria. Next, come to the WHO criteria. There is one Jones criteria and there is another one is a WHO criteria. And WHO criteria, actually this, remember the Jones criteria, this is mainly used for the first episode, like when the patient initially, when he got affected with this rheumatic fever, the first episode of acute rheumatic fever, for that we use the Jones criteria. And WHO criteria, we can use it both for the first episode, because often the patients who develop acute rheumatic fever, they can get again recurrent episodes of rheumatic fever. Okay, so first episode plus the recurrent episodes of rheumatic fever. For both of them, you can use if you want to find out. Okay, so the this thing of a patient, suppose who has been again affected. Okay, so there is a recurrent episode of rheumatic fever. For that, you can use the WHO criteria. Okay, so if the patient has reported to you for the first time, if it's a first episode, then the criteria is same as that of the Jones criteria. So it is same as that of the Jones criteria. Okay, and for a recurrent episode, like the patient was already affected once and this is the second or third time the patient has come to you, it's a recurrent episode. See, in a patient without a established rheumatic heart disease, so if the patient doesn't have a established rheumatic heart disease, we'll divide this recurrent episode into two things. If the patient already had a, there was an established rheumatic heart disease, and the second is that if the patient didn't have an established rheumatic heart disease. So, right. So here we were talking that in the recurrent episode, if the patient presents, without established rheumatic heart disease, because if the patient is not, without established rheumatic heart disease, then you will classify the patient. Okay, so whether the, the probability, whether there'll be a high probability of acute rheumatic fever or not, that is as per the first episode. Okay, as per the first episode, as we had done it according to the Jones criteria, the same way we are going to do it in a patient without a established rheumatic heart disease. And if the patient already has an established rheumatic heart disease, in this it requires only two minor manifestations, plus, as I told you, there has to be the evidence of a prior antecedent group A streptococcal infection as per Jones criteria. It's without RHD as per the first episode. With RHD, just that you have to, there are presence of two minor criteria plus evidence of antecedent group A streptococcus infection. Okay, and if the patient presents to you with chorea, okay, so if the patient presents to you with chorea and indolent carditis, if the patient presents to you with both chorea and indolent carditis, so in this indolent carditis, so if the patient, according to WHO, they do not require any additional evidence of this antecedent streptococcal A infection. Again, repeat to you, Jones criteria, I told you, that is the major criteria, minor criteria. WHO, if it's the first episode, the patient has come to you the first episode of acute rheumatic fever, same as Jones criteria. Recurrent episode, you evaluate the patient has an established RHD or not. No established RHD, again, as per the first episode in Jones criteria. And if the patient already has established RHD, rheumatic heart disease, If his heart is also involved, established rheumatic heart disease, then just 2 minor criteria. Plus, as we had seen in all the patients of Jones criteria, we always even if the patient was, we were taking 2 major criteria, 1 major, 2 minor, but always we had to take evidence of the antecedent group A streptococcal infection. So here also 2 minor criteria plus evidence of antecedent group A beta hemolytic streptococcal infection. Okay, and if the patient presents to you with both chorea plus indolent carditis, in this case only, you don't require any more evidence of antecedent group A streptococcal infection. Right now, there is one more thing which is called as the revised Jones criteria. Revised Jones criteria. This was in 2015. Revised zones criteria 2015. So revised zones criteria, here just an additional some things were added. That is, here we had identified a low risk, medium risk, and a high risk. Low and medium. Okay, so low and medium to high risk population was identified. And accordingly, the major criteria, they were divided. Like there was some, obviously the people who are at high risk, even you see the slightest of symptoms. Okay, so you should immediately, that will carry a high probability that the patient might have acute rheumatic fever. Low and medium. So like this, the patients were divided into 2 groups. Okay, the low, medium, and the high risk population. Okay, so this is it. And diagnosis first at the low risk population, that is in one in which the cases of acute rheumatic fever, they occur in less than 2 by 1 lakh school age children, or rheumatic heart disease is diagnosed in less than 1 by 1,000 patients at any age during 1 year. And in these cases, in the low risk patients, the diagnosis of the first episode of rheumatic fever, as I told you, it requires the most important thing is that it requires evidence of the same thing as I had told you in zones criteria. It requires, this is a revised zones criteria, and the revised zones criteria, remember, the only difference is that they have classified the patients into a low, medium, high risk and a high risk population. Okay, and accordingly they have fixed the criteria. Low, medium, the same thing which we discussed just now, that is there is the prior evidence of a antecedent group A beta hemolytic streptococcal infection, plus what did I say you, 2 major or 1 major plus 2 minor criteria. Right? So, and the diagnosis of subsequent episodes of rheumatic fever, that requires a confirmation again of 2 major, or 1 major and 2 minor criteria or 3 minor criteria. Diagnosis, this is the first episode. Low risk population, diagnosis of the first episode of rheumatic fever. According to the revised Jones criteria, this is the first thing. The population were divided into low risk and high risk. And second thing is that the diagnosis of the first episode, when the patient comes to you with the first episode of rheumatic fever, first time the patient has been diagnosed with rheumatic fever, this is the diagnostic criteria. And the recurrent episodes, what is the diagnostic criteria? Recurrent episodes of rheumatic fever, this again requires a confirmation of 2 major or 1 major, plus 2 minor, right, or 3 minor criteria. You can see this 3 minor criteria, this was not there with the first episode, right? And so this is all about it. So the revised Jones criteria. Then next come to the management of this acute rheumatic fever, the most important part, the management. In fact, the entire thing is only important. Management of acute rheumatic fever. Remember the number 1, that is bed rest. Okay, so bed rest should be advised till the temperature and the ESR becomes normal. And those patients who had carditis, they should continue a little bit prolonged more period of bed rest, at least for 2 to 6 weeks after the ESR and temperature has returned back to normal. Without arthritis, just bed rest till the ESR and temperature comes back to normal. And if the patients are affected, if the heart is also affected, if the patients have developed carditis, at least additional some more bed rest is required in those patients. Okay, and what else? Anti-streptococcal therapy. So of course, even if the throat culture has come out to be negative, you have to give an anti-streptococcal therapy. So which is the antibiotics to which the streptococcus responds to, that is your penicillin group of antibiotics. Okay, so anti-streptococcal therapy. Anti-streptococcal therapy, like you can give a single injection of benzathine penicillin, benzathine penicillin, as you say. Okay, so benzathine penicillin, this is given, a single dose of benzathine penicillin is given by the intramuscular route, 1.2 million units. A single dose. You have to give an anti-streptococcal therapy, even if the throat culture comes out to be negative. Or if the patient, there is one more thing, that is the patient can also take a daily, 10 days daily injection of procaine penicillin. If the patient is taking procaine penicillin, then you have to give 10 days daily. This is a single dose of benzathine penicillin, and this is for 10 days. Okay, procaine penicillin, 10 days procaine penicillin. This is taken 600,000 units intramuscularly. Okay, and other patients also, we can give some, nowadays usually the oral medicines are given. What oral medicines can you give? Tell me. The oral erythromycin. Okay, so you can give erythromycin, azithromycin. Okay, so erythromycin. In those patients, who are sensitive to penicillin, if they are not, they are sensitive to penicillin, in those patients, you can give the other macrolide groups, that is erythromycin, or you can give azithromycin. Azithromycin is commonly given, very, very easy dosing regimen. That is, we usually give it in a dose of 500 mg once a day for 5 days. Okay, so azithromycin, erythromycin. Okay, so these drugs are preferred in those patients who are sensitive to penicillin. Okay, so you gave an anti-streptococcal therapy. Okay, next, what else you are going to do? Now the patient has come to you with polyarthritis, all his joints and all are involved, and there is inflammation. So what are you going to give? You're going to give salicylates, that is aspirin. Okay, so aspirin, it is helpful in providing symptomatic relief. You usually start it at the dose of 60 milligrams per kg per day, and we give it in 6 divided doses. Total, how much, whatever the dose comes out, we give it in 6 divided doses, and the dose is gradually increased. But if the patient starts developing side effects, we immediately reduce the dose. Okay, and we just aim that the inflammation that should subside, and the ESR, after the ESR comes down normal, we just wait for the ESR to come down to normal. Until the ESR is normal, we continue aspirin. And then gradually we are going to taper it down over a period of 4 to 6 weeks. Gradually we are going to taper it down, okay, so over a period of 4 to 6 weeks. Correct? Right? So then what will happen if the patient has got severe carditis or severe, arthritis, which is not responding to penicillin? What is the next drug which we give? That is your corticosteroids. Remember, if the patient has got severe inflammation, which is not responding to aspirin, in those patients or who have got severe carditis and they have also developed heart failure, they're not responding to aspirin. In those cases, we give corticosteroids. So corticosteroids, we prefer prednisolone. We give it in an oral dose of 60 to 120 milligram. This is your starting dose, which we give it per day. Okay, and then we wait, we continue we do the ESR testing, and we just wait for the, we give the corticosteroids till the ESR comes down to be normal. And then after the ESR comes out normal, what are you going to do? Are you going to suddenly stop it or going to taper it down? Always remember, corticosteroids should always be tapered. They should never be suddenly stopped, especially when you're giving such a high dose of corticosteroids. Okay, so gradually you're going to taper it down over a period of 4 to 6 weeks. Okay, and sometimes what happens is that in some patients, like once we stop these steroids, there is again a rebound of the symptoms. Again, there is a rebound, post-steroid rebound. So in those cases, to prevent this post-steroid rebound, when we are tapering down the steroids, we add aspirin. Okay, there is an overlap period of aspirin, overlap course of aspirin when the steroid is being tapered down to prevent the post-steroid rebound. Okay, and whenever you are giving the patient aspirin therapy or corticosteroids, we always monitor, we keep on monitoring the ESR and the CRP levels of the patient. And apart from this, what are other supportive therapy you can give the patient? Like if the patient has developed heart failure or valvular lesions or heart blocks, you give the appropriate treatment regarding that. Okay, so this is what if the patient has developed rheumatic fever. Achha. Now, what will you do for the primary prevention? Primary prevention, the prevention of the initial rheumatic attacks. Like usually what happens, there are some endemic regions where this prevalence of rheumatic fever and this streptococcal infection is very high. So how will you, there are two things. One is primary prevention. Primary prevention, you are preventing the first episode of rheumatic fever. Or there is another thing which is called as secondary prevention. Secondary prevention means the patient has already developed rheumatic fever. You have to prevent a recurrence of rheumatic fever, because just now I told you there are high chances that the rheumatic fever can again recur. Usually the secondary prevention, this is carried out for a long duration, for 5 years, or even longer durations. I'll just tell you. Okay, so until 18 years, until 25 years of age, secondary prevention is carried out for a longer time, because the patient already had a attack of rheumatic fever. So there are high chances that he can again get it. Okay. So primary prevention, first most important is that if the patient has developed a streptococcal infection, you should carry out the proper treatment of the streptococcal infection. And if there is an outbreak of rheumatic fever in a closed population, first is most important is the treatment of the pharyngeal infection. Treatment of the pharyngeal infection. And if there is an outbreak of rheumatic fever in a closed population, you should always go for a mass penicillin prophylaxis. Mass penicillin prophylaxis. And if the patient, has a established already, that by the throat culture, you did the throat culture and you found out that yes, the patient is affected with group A beta hemolytic streptococcus. In that case, what are you going to do? You are going to give the patient, they are to be treated with that same anti-streptococcal therapy which I told you. What was that anti-streptococcal therapy? Anti-streptococcal therapy I told you, that was with, remember, benzathine penicillin. What else had I told you? Procaine penicillin. And if the patient is sensitive to penicillin, what are you going to give the patient? You're going to give the patient azithromycin, or you're going to give the patient, yes, erythromycin. Okay, so this is if the patient already has an established streptococcal pharyngitis, we give these drugs. And usually in certain communities, this rheumatic fever is endemic. Like many people get this rheumatic fever. In those communities, any child, if he or she, has got a history of sore throat, once a patient, not history, once a patient develops a sore throat, and if the patient comes to you, if the child comes to you, mainly in the age group of 5 to 15 years, if the child comes to you with a complaints of sore throat, and that this rheumatic fever is endemic in that area, you should always regard it as a streptococcal infection and you should treat accordingly. Okay, so you should give these anti-streptococcal therapy. Right. So next come to the secondary prevention. Secondary prevention means the patients already had developed, they have already experienced a documented attack of rheumatic fever. So there are some outlines regarding the duration of the treatment. Like one thing is that if the patient had, you'll take the history from the patient, you'll see the previous reports from the patient. He must have kept the previous reports from, from his previous treatment. If the patient hadn't developed any carditis, there we'll do one type of treatment. If the patient already had developed a carditis, but that carditis has resolved, okay, resolved carditis, resolved carditis. And the other case is severe rheumatic heart disease, or in, the patient also, he required a surgery is required. In those cases, what to do? Okay, so if the patient has not developed a carditis, so usually we continue the prophylaxis. The duration of the prophylaxis that is given for around, what is the prophylaxis? I'll just tell you the prophylaxis. That same thing, the benzathine intramuscular injection of benzathine penicillin that is given every 3 weeks. I'll just tell you the prophylaxis, but just let me first tell you the duration and then I'll tell you what prophylaxis am I talking about. No carditis, here the prophylaxis is continued for 5 years or until the patient is 18 years old, whichever is longer, either 5 years or till the patient is 18 years old. If the patient had developed carditis, but it has resolved, in that case, we give the treatment for 10 years or till the patient is 25 years old. This you have to remember, very important. The patient has developed a severe RHD or, surgery was required. In those cases, you have to give the prophylaxis lifelong or at least till the patient is 40 years old, till the age of 40 years. At least till the age of 40 years, preferably lifelong. right? Now, what am I saying? Like prophylaxis for 5 years. What prophylaxis are we going to give? That I'll just tell you. The most preferred prophylaxis is injection, intramuscular injection of benzathine penicillin. This is the most effective and the most preferred prophylaxis. That is, this is most effective also. Okay, so benzathine penicillin, that is given how much? 1.2 million units is given intramuscularly, and it is given every 3 weeks. Okay, oral penicillin, you must have learned about oral penicillins also. Oral penicillin V, this is less effective than benzathine penicillin. So this is usually given 500 mg twice a day, but it is less effective than this intramuscular one. This is given by the intramuscular route. This is given by the oral route. Okay. And if the patient, what if the patient is allergic to penicillin? Okay, so if the patient is not sensitive to penicillin, allergic to penicillin, in those cases, as I told you, you're going to give the patient erythromycin 250 mg twice a day, or we give the patient azithromycin 500 mg once a day. But only if the patient is allergic to penicillin, then only we give it. Okay, and one more drug is also there if the patient is allergic to penicillin, that is sulfadiazine. Sulfadiazine 1 gram per day orally. Sulfadiazine, so this is given in a dose of 1 gram per day orally. This also can be given. Okay, so this is very important. So this ends your chapter on rheumatic fever. So rheumatic fever, you need to know the etiology, you need to know the symptoms, the revised Jones criteria, WHO criteria. Most commonly, the Jones criteria is asked, most of them ask you about the Jones criteria. Should remember about the major criteria, minor criteria, and what are the criteria, which you need to fulfill to say, that which increases the probability that the patient has got a rheumatic fever, 2 major, okay, or 1 major, 2 minor. Okay, so all these things you need to remember, plus, evidence of antecedent group A beta hemolytic streptococcal infection. You need to know the management, and prophylaxis is very, very important. Often the prophylaxis is asked to you that you should know, like what is the primary prophylaxis, secondary prophylaxis, what is the duration of the secondary prophylaxis, for how many years you have to give, in which patients, how many years, in patients who didn't have, carditis, in patients whose carditis was resolved, and in those patients who had developed severe carditis or rheumatic heart disease. So what's the duration in them? So this entire thing is different, and by this time you all must have understood that the etiology, is completely different from that of rheumatoid arthritis. Although here also the joints are affected and there is arthritis, but the cause of both of these is different. Rheumatoid arthritis and rheumatic fever, the etiology is different. Okay, so this is all about the rheumatic fever. Next class we shall have a class on we'll start on the mitral stenosis and mitral regurgitation and all. Okay.